to talk about something today that I hope is applicable to everybody, which is really about longevity in emergency medicine. And how do we keep our groups engaged? How do we keep our groups moving forward in an era, as was talked about in, I think, 2 presentations ago, of increasing contract groups. All these things come to play. So we're calling this How to Restructure a Physician Group and Change Culture. So a couple rhetorical questions for you guys. Does anybody here have a hard time getting all their docs to buy into things? I mean, I don't know about you, but does anybody, here's one. Does anybody have a hard time getting their docs who don't do any admin work to volunteer for things? I don't know. Does anybody, who has a hard time disseminating information? The leadership makes a decision. How do you get that information to the person who only works night shifts? Or who feels like the burdens of administrative work are actually more now than they were 5, 10, 15 years ago? So maybe it's just us, but those are kind of some things that have been affecting our practice. So a little bit about who we are, but the vast majority of this presentation is actually going to be about who we are. So we are a Democratic group. We have an exclusive contract with one healthcare system in the South Puget Sound region. They have 6, which is called Multicare. They have 6 ERs, 5 hospitals. We staff 3 of their ERs, 2 of which are attached to hospitals, and 1 of which is a freestanding emergency department. And as of now, we have, plus minus with some part-timers, about 40 physicians, 8 mid-levels, and 2 administrative staff. So where we were August 2012, we had docs who across the board felt they were working too many shifts. We really had identified difficulty communicating amongst the group. And we had some disgruntlement with our leadership, which I'm one of. And we'd hired about 15 new physicians in 2 years. And so a lot of this, in August, Steve and Dan are with me. Our board of directors, we were just hearing rumors of disgruntlement, rumors of docs griping not just to each other but to nursing staff. And so it was a little bit of a hint that so maybe we have a problem. And so the question is, how do we, before we define what the problem is, I think we have to say, why are things different now than they were a year ago even? So, and I'm going to summarize this by just saying we've had massive change in our group over time. And so when I started with our group in 2003, we had about 15 physicians, 2 ERs, almost everybody wanted to work 8 14-hour shifts a month, and 5 board of directors. 2012, we had 40 physicians, so we went from 15 to 40. Most now wanted 12 shifts. Nobody wanted to work 14 shifts anymore. We picked up an additional contract, and we had a freestanding ER that opened in April of 2012. But we had the same structure. We had exactly the same structure that we had 10 years before. Now we had this brand new ER that had just opened. And so a couple other background information to that is that we were, most of you know, a lot of times if you're going to hire a bunch of people, you're trying to recruit sometimes people coming out of residency. There's sort of a hiring cycle that happens. New physicians oftentimes become available after they finish their residencies or their fellowships. It's the summertime. You have to start recruiting ahead of time. But we were opening an ER in April. And so we were going to be 8 months off of when the vast majority of the new physicians would be starting. And so we'd worked out this deal with the hospital to sort of hire people in advance. And so for the first part of the year, we had people who were fighting for shifts. And then after we opened in April, now suddenly, people we were working more than they had wanted, and we did add an additional physician shift at one of our other hospitals. So the bottom line is people felt like they were working too much. And again, we still had the same structure. And so this change over time, this new freestanding ER and hiring of 10 plus physicians in one cycle, it really it exposed the weaknesses of our administrative structure. So the things that were there were probably there, but talking about introducing all this new change just exposed where we had some weaknesses. Couple other things, we had this culture change where over 10 years, the amount that people wanted to work had changed. Objectively, it had changed. And then, of course, everybody still wants to make the same amount of money. I probably didn't need to put that up there. I suspect everybody already knows that. It's just some additional pressure points. And so this is sort of where I would, the last slide and this slide are kind of like our identified problem, which is that, the work is harder now than it was 10 years ago. Acuity is higher. In a lot of places, even if the total number of ER patients has been flat or gone down, the acuity is definitely higher. You're admitting more patients. That means the work is harder objectively. A lot of our younger docs, they just did not want to work more than 12 hours. And our contract is set up such that everybody is guaranteed 12 8-hour shifts a month. And a lot of people took that to mean, well, that's all I have to work, right? And I think all of us know that in practice, oftentimes you have to pick up extra shifts for coverage, et cetera. And then the real problem, though, and we got objective data on this, is that a lot of the docs just felt that our board of directors was too closed, too corporate, didn't have the physicians' backs, and some examples of that may or may not resonate. We were viewed as being too corporate because we were really concerned with contract security. We have an exclusive contract with one healthcare system. We did not want to lose that contract. And so we would do everything we could to kind of align with the healthcare system. And the healthcare system is a pretty quality-oriented system. But oftentimes that just came across to our docs as, well, you're just doing what the administration says to do. And some of this didn't have the physicians' backs, I think, came from a sense that we are a very quality-focused group. And so anytime there'd be a quality issue and would get pointed out, it was oftentimes perceived in a negative fashion, or you're coming down on me, and I'm a doc in the trenches, I'm doing the best that I can. And then another key point is, we tried really hard to get information out. We just couldn't do it. We'd send out emails, people wouldn't read emails. Does that ever happen to anybody else? So these are, I think, ubiquitous problems in emergency medicine. And then to kind of top things off, we were also in the midst of a really difficult contract negotiation. So the question then becomes, why change? And I'm going to kind of summarize our problems in this slide, which was, so all of the power, we were Democrat, keep in mind, we are a Democratic group. So to Manuel's point earlier about, is Democratic group always good? Well, it probably is, but in our case, we had all of the power, all of the information, all of the financial decisions, a lot of the peer review and quality determinations, and the personnel issues. They were really concentrated in the 5 board of directors members. Now we were elected every year, and on major decisions, the partners would vote on things. But unless you really had in-depth knowledge of what was happening week in and week out, that felt closed. All of those comments that I put up before. And then we had some quality and HR issues. Our attempts at creating a very rigorous peer review process they had alienated people. They felt they were under the microscope, and some felt uncomfortable passing judgment on their peers. And then a point I'm sure everybody knows, but the more people you have, the more challenges you have. Increased doctors, you're going to have more personnel issues. And again, we had the same structure for 40 doctors that we had for 5 doctors, or for 15, and it was a challenge. So where did we start? So we'd identified that we had a problem. We'd identified it was a problem of culture and perception and quality of life. And so we started out with a shareholder meeting of all of our partners to kind of air out the concerns. We sent out a survey. We had people, anonymously tell us how they felt, what they were thinking. We took all that down. We aired it out. And then we actually started doing surveys and follow-up to try to see if we were making any improvement by emailing, trying to disseminate more information, trying to be more transparent. And we were not successful. And I think the reason we were not successful with that is because we were operating within the same system, which was all of those power decisions with the same 5 people. And so then the question becomes, well, so why do you want to go to all the trouble of restructuring? And we clearly we had job dissatisfaction with our physicians, so that was one reason. And then I'll talk about this in a few minutes, but we realized that in this contract negotiation, we were probably going to have to switch to a new compensation model. We needed group buy-in for that. And then, and I say this here, that we needed to save our group. It wasn't as if the group was going to fall apart right then and there, but to me it seemed like if we don't make changes now, 12 months, 18 months down the line, we may be dealing with a situation like what Manuel was talking about of, could potentially a contract group come in and take what we had worked so hard to build. So just a quick diversion on what were our contract issues. So the current compensation model up until now has been, we negotiated $1 per RVU from the healthcare system, which is kind of an old school way of getting compensated. So we'd submit our RVUs every month and get a check from the hospital. We weren't doing any of our own billing or collections. Multicare wanted to decrease our subsidy, so there was a subsidy built in. Market research showed us that a subsidy in our market probably meant you have a target on your back. And that was enough to really drive change for us. And then we had this other issue that our group was pretty nervous about change. We'd had this model for a while. People really perceived that our payer mix wouldn't support that. But if you remember back to our first slide, we did have a freestanding ER that opened in April of 2013. And that was a gamble to take that contract. But we did it because we were pretty sure the payer mix was going to be good. And in fact, it did turn out to be as good or better than we had anticipated. And so with this newer contract, we were able to figure out that maybe we could make this work. So change. So before we made any change, so we got bids from billing and collections companies, as well as a practice management company, PSR, who somebody else referenced earlier. I can't remember. Is that you, Jeff? So I don't even know what PSR stands for, but they do contract management for a couple of the groups in the room here, or practice management. But we realized this change was going to actually require more work, not less administrative work. But meanwhile, our group, because of this frustration, they wanted us picking up more shifts. They thought, well, gosh, you guys should carry more of the load in the trenches like we are. So how are we going to do this? We've got this mountain of work to do. So we did our research. So this is our process. So we got our bids. We assessed our situation, both in terms of our situation with group happiness, and we also assessed our situation through these people we were getting bids from in terms of, how realistic is it that we can do this? We realized we were a little bit too fat clinically. We had too few patients per hour overall, probably not enough mid-level coverage. This is interesting. We had an uneven distribution of overtime. People were charging overtime on an honor system. We went back and did an assessment. There was a $20,000 difference from the highest to the lowest person. And these people were all doing about the same amount of work. And of course, by the way, the top 5 overtime chargers were the bottom 5 lowest productivity people. So does that surprise anyone? No. Yeah. And then this last one, the board of directors members were exhausted. So the proposal was, so we developed a plan to create so that we could transition to a new model of compensation, and that basically came up with decreasing expenses, increasing revenue, hiring a practice management company. So how are we going to do that? We're going to decrease expenses, and so some of this was a little bit of a deal that we were negotiating with our shareholders, our partners. So we felt that in order to offset the costs of now paying for coding and billing, bringing in a practice management company, and to offset a little bit of the perception that the board of directors weren't kind of carrying their weight, we said, well, we need to cut our administrative costs across the board by 20%. And so we made that commitment. Then we said, well, we need to, because we're a little fat clinically, we decided to eliminate one physician shift, essentially half of the week, and replace that with a mid-level, because we looked at the days of the week and where the volumes were, and we thought that that was justifiable. And then we just said, let's get rid of overtime, because the truth is, we don't have an accurate assessment of where we are from a productivity standpoint, because we have such a range of how much people were reporting. And then we need to increase our income. That's the other thing we need to do. So one thing we talked about is increasing individual productivity, and I'm going to talk a little bit about that at the end. And then we needed to improve our collections. And so we weren't really billing for any ED observation, not an observation unit, but just ED observation. Talk a little bit about ultrasound, and then improve our critical care. And so really the billing company and the practice management company were going to help us with that. And then the key, though, was to restructure our administrative structure to support the work that we're now doing. And so a couple of the goals of this were we needed to disseminate knowledge. I mean, all of our board of directors knew how hard we were working, but our physicians, they just didn't appreciate it. And I don't think that's a unique situation to us. I really don't. I think that's an inherent problem of emergency medicine, and we've touched on that a little bit today already. We needed group buy-in because we were going to be taking a risk. And then this is the key, though. We had to spread the cost of doing more work for less pay across all the docs, not just the board. I mean, you can't just have your administrative docs taking all of the hit on this 20% cut, and have the folks who weren't doing any not take any of that, because we're going to have more administrative work to do. And then one of our other goals was to transfer some certain administrative work to the practice management company. You can't switch all of it to them, but we could get some of it. And so what we decided to do, we did a bunch of research, and we decided to create some committees. And so previously what would happen is we'd ask someone if they wanted to volunteer for a committee, for a hospital committee, or do some project, and then they would submit time. They'd sort of say, well, I work this many hours on the honor system, and then they would get paid for that. And we set our administrative pay equal to our clinical pay, kind of on an average system. So we decided to move to a stipend system, including the board of directors, and that's how we were going to get to that 20%. Because we knew how much we'd spent on it the year before, and so we said, okay, this next year, we're going to only spend 80% of what we spent last year. So now we had to figure out how to disseminate that across the group. So we're going to maintain the same rate, which was admin work equals clinical work, and then we assigned every physician to one of 5 committees. And so each committee essentially got a certain amount of money. So each board of directors person, medical director got a stipend, and then some of that went to the committees. So finance, operations, peer review quality, human relations, personnel, and then best practice. And best practice is anything new you want to do, or evaluating what's the best way to manage such and such, what's the best way to document risk factors for subarachnoid hemorrhage. And so we did all of that. You know, I think I'm one slide reversed here. So what happened? So we presented this in November. We had a lot of disgruntlement walking into our meeting November 20th. And we walked out with unanimous endorsement of our proposal. People were actually clapping and standing up. They were so excited. We successfully, in the next 6 weeks, negotiated a contract with our hospital system to transition to doing our own coding and billing under the most ideal circumstances that you're going to find in this environment. We got immediate engagement from every single one of our physicians. And then better communication, and the dialogue in terms of the tone of it started turning around from the second that we made that proposal. The level of engagement was astonishing. And then I'm just going to go back one step here. So how do we do this? Positivity is sort of a goofy word, but I think it sums it up, is that none of this stuff was possible without an overwhelming commitment to being positive and to encouraging our physicians. Some other tools that we've been using are rounding. So going in, seeing, so board of directors members going to the ER on their non-clinical days, going and rounding on their docs, asking questions like, what is one thing I can do today I'm not going to fix everything, but if you could just give me one thing I could do that would make your life better today, and doing it with a nurse with you, like a nurse leader, so you could actually affect change. Some of it's as simple as getting 4% lidocaine, so everyone knows where 4% lidocaine is, because one person really liked doing awake intubations and you wanted to put them in an SVN. And so we got that done that day. And people actually see you're doing something positive. And the other thing about rounding that's amazing is if you go on, as a leader, you go and round on patients that are in the ER with a nursing leader, because doing it together is really powerful. Every time I do that, I get at least something from every patient where they name someone who did a great job in their care. They might have been pissed at the doctor, they might have been mad at the registration person, but there was a tech that they liked or a nurse that they liked. If you do this and then you then pay that compliment forward, so every time I round, I would write it down, I'd go directly to a computer, email the person that did the good job and their supervisor. It changes how you view the world as a leader to do that. Because suddenly you're starting your day with sending, how nice is that? You need to start your day with sending a compliment. You know, the response to that is amazing. Committing verbally to really caring about the quality of life for our docs, and then backing that up by hiring. And so we were able to hire 10 people since November. They haven't all started yet, but even knowing people are going to be starting helps make that sense that I'm not going to be working all these extra shifts forever. So a few lessons learned, and I will say, before I go through this slide, I'll say we're starting our new compensation, or starting doing our collections and billing July 1st. So we're just about to start that process, and I'm sure we'll have a whole different set of experiences to report out next year, but we've taken the time to get everything set up right, and we're very positive about how that transition is going to happen. And so a couple of lessons learned. We spent the last, since November to now, essentially preparing for this time. We've gotten everybody in committees. We've gotten great level of engagement. You know, everyone knows this, communication is critical, but some things that we've learned is that you need multiple venues, you need frequent remessaging, and you need to do it over and over and over again. So oftentimes this issue, some issue will come up, and we'll say, gosh, didn't we just talk about that like 3 months ago? And everyone gets frustrated by it. You got to just accept that. You got to say, I'm going to have to message the same thing over and over and over again. And some people still aren't going to get it, but still you got to do it with a smile on your face. As the leader, when you're like, oh, I can't believe you didn't get that. You know, people, they just don't like that. They just don't like it. And then the committees allowed us to have the same discussions in more venues. So a couple of the medical directors sit on more than one committee. And so I had the same committee, same discussion in my best practice committee meeting as I sometimes do in the operations committee. And yeah, that might feel like duplication, but you're getting the same message out there. And when you have these difficult discussions in small venues, you get engagement, you really do. And so this cross-referencing of operational issues across committees is really important. More discussion dissemination of knowledge is important. People, they just want to know what's going on. If they don't know what's going on, they're going to make up their own story. I mean, it doesn't matter how good a job you're doing, how much they're making. If you don't continually tell them what's going on, they're gonna make up their own story. And then this one is key, which is, you know, transparency equals trust. And so, you know, we were accused of being too closed, and we weren't trying to be too closed. We just didn't have the tools to message enough, and so that felt like closed. And so you get trust when you're transparent with people. There are some challenges that we're still working through. Does the left hand know what the right hand's doing? When you separate things out into committees, you sometimes will have a little bit of duplication of work, and we're kind of working through that. Our board isn't spending every waking hour together anymore. For some people, they're a little bit off-put by that. They don't quite know what to do. For me personally, that's been better for my family. What do you do about non-participators? In my particular committee, there was one guy who wasn't showing up very much. He was an older guy about ready to retire, and the rest of the gang were all pretty new physicians. And so he was a little late showing up to our last meeting, and I said, hey, where's John? And the other guys in the group, they said, well, we talked to him last week. We said, you haven't been to any meetings yet. I mean, these are people, not even partners yet. And they felt empowered to say to one of the most senior guys in the group, I don't see you participating. I'm hoping, and the young one said, hey, we have a meeting on Thursday. You're going to be there, right? And I was so proud, and then he walked in about 5 minutes later, and that worked out great. You know, how do you create a collective memory when you have people doing different things? So those are things to still work out. How do we measure outcomes? So right now, the outcomes that we're talking about are pretty subjective. It's physician engagement. It's, what's sort of the tone of our meetings, what kind of feedback am I getting as we move forward with doing our own coding and billing. We're going to have some more objective data, and then we've got people doing some administrative activities who don't really have experience in it, and so getting them up to speed is taking a little bit of effort. And then one last thought here on this positivity and productivity. There is a very strong correlation in the psychology literature between performance and what's being called prime for positivity. A lot of this research comes out of Harvard by a guy named Sean Achor. Has anybody heard about him? Seen any of his TED Talks? If you look up any of his TED Talks, are fascinating. Yeah, and what? Yeah, he's a young dynamic guy, and he's taken some very interesting literature. It's A-C-H-O-R, Sean Achor, A-C-H-O-R. And what he's done is he's taken some literature or some basic science stuff, and he's packaging it in a way that's really applicable. And the bottom line is that if you take people, it doesn't matter if they are children building blocks or if they are salespeople, and you set them up in 3 scenarios. One is like no preconceived notions, you let them do what they want. Another is you have them read scientific literature. This is the doctors. So they're like in a scientific frame of mind. Or you have people do some positive activities so they're in like kind of a good mood and thinking positively. And then you have them try to do diagnoses. The people primed for positivity are 50% more accurate and 50% quicker. I mean, this is unbelievably astonishing. If you do this with children, if you do this with 4-year-olds, they build blocks faster and they do it more accurately. It doesn't matter what activity, people and teams primed for positive action perform better and they enact change more quickly. And we don't talk about that in what we do very often. A lot of times it's about diagnosis. But if you're not going to take someone who has an IQ of 60 and turn them into someone with an IQ of 120, but you can get the best out of that 60. If you can get the best out of what you have, I mean, why wouldn't you want to do it? Is my question. And team members that feel valued perform better regardless of their skill set. So some final thoughts. There are so many negative messages about the work that we do in emergency medicine. There's fears about our contracts. There's fears about reimbursement. There are fears about what does the Affordable Health Care Act mean for us. There's negative messages. At almost every ER meeting you go to, there's a negative message, right? Don't get sued, right? We have to create positive messages for our groups. And I do not say this lightly. They are life-giving. You can give someone back their life in emergency medicine by creating an environment in which they can be successful. And you can't do that if they don't feel valued or if they're not happy in what they do. And I really believe this, that physicians are dying to hear that our leaders, medicine's leaders, create a vision they can embrace. And so I just kind of want to end by encouraging everybody in this room, because I know that's what everyone's trying to do, and to just kind of end on a positive note that we can create a vision that our physicians will get behind. And that is how I think we prevent contract groups from taking over, how we continue to own our own practice. So we can do this. That's it.